So let's go to our third presentation, our final presentation for this webinar. And joining us live now is Kenny Vuong, a physiotherapist, former senior of physiotherapy at St Joseph's Hospital in Sydney, the only Huntington's disease specialist residential care service in New South Wales. So welcome with deaf sign clapping to Kenny. Thank you.
Hi everyone, thanks for having me at this conference. So just a little bit about me. So yeah, I've worked with people with Huntington's for close to about 10 years now at St Joseph's Hospital. And so my presentation today will focus a lot on falls and rehabilitation for people with Huntington's disease. So I'm just going to share my screen. So if I could ask if you could allow me to share my screen there, Lewis.
Make Kenny co-host so he can share screen.
And hello to everyone from St Joseph's. I'm just trying to share my screen still.
And if you could let us know, Lewis, what's happening. I'm sure you're endeavouring to make Kenny a co-host so that he can share screen.
Yeah, so I'll just keep talking whilst we're waiting for that to occur. So what we'll go through today is just quickly the current evidence for gait, balance and falls in Huntington's, and then we'll briefly go through the current recommendations for what therapists should be doing with people with Huntington's disease. We'll then go through some preliminary results we have from our HD4 studies that we did at St Joseph's, and we'll talk a little bit about future directions. But I know the vast majority of the audience will be people with Huntington's, their families and carers. So a lot of what I hope that people can get out of today's talk is some more empowerment as to what it is that you need to have if you have Huntington's. If we can think about scenarios where your NDIS application is coming through, or your yearly review is happening, and you need to advocate for yourself or for your loved ones in terms of what you need to get, hopefully some parts of this talk will help you do that. So I'm just still waiting to share my screen, but I can just start talking anyway. So in terms of gait, so the walking for people with Huntington's, it's not just chorea that's the main feature here. So we all know what chorea is, with the movements, the extra movements with our body. But there's also other things that may not be so obvious. So one of the main ones is our walking speed does decrease if we have Huntington's. Our rate of stepping, so the amount of steps we take for a certain period of time, our cadence also reduces, as well as our step length or our stride length. There's also greater variability from step to step as well. So it's not always a consistent step that we have.
Kenny, could I just come in? You are now co-host. Thank you.
Yep, I'll just get that up now. Right. Just get the oops. Sorry. Apologies, everyone, while I just get this going properly. There we go. Great. Everyone can see that? Yep. And we'll talk. Yep. And so, yeah, and we're talking about increased variability between the stepping, as well as there's more time spent in double support. So the time where both of your feet are on the ground during your walking, that's a sign of how good your balance is. So if you're spending more time with 2 feet on the ground, that's generally a sign that your steadiness may not be as good as it was. And the other thing to note, and the first presentation alluded to this, was doing 2 things at once with your walking does impact on the quality of your walk. So if you're walking while you're talking, thinking about something, scanning the horizon, scanning the ground for obstacles, and this can be quite tricky, and this can impair your walking a little bit more. In terms of falls, it's two studies that had some figures about it, where they found in the last 12 months, 76 to 79% of people with Huntington's had a fall. There's some other work there to also detect fallers with outcome measures. So what we have here for recurrent fallers, so they defined people who had 2 or more falls as fallers and people with 1 or 0 as non-fallers. And they found that in a timed up and go test, which is to stand up from a chair, walk 3 meters, come back and sit down, that if you could do that in under 14 seconds, you had less risk of falling. So a score of 14 or over means you're at greater risk of falling. With your Berg balance, which is a measure of many different balance tests put together, if you're scoring 40 or less, then you're at high risk of falling. And the Tinetti test, which is a test of balance and your gait, if you're scoring 21 or under, then you will be at greater risk of falling. And with that test, they did have a sensitivity number there of 74%, which is to say that it would pick up a score of 21 or under would pick up 74% of people who are actually high risk of falling. Other things that can contribute to falling are environmental factors, multitasking like we spoke about, and perhaps even cognition. I think the bottom line here is that falls are multifactorial. It's not just your walking, it's not just this or just that. Often it's a multifactorial causes of falls. Now, in terms of what we are doing now, what the current evidence says, there's a great paper that's come out in 2020, the clinical recommendations to guide physical therapy practice. And it recommends that with aerobic and strength exercise, there's a strong recommendation to do moderate intensity exercise, so 50 to 90% of your heart rate maximum, combined with resistance training, so weights or body weight exercises, anything to build up strength, and to do that 3 times a week for at least 12 weeks. Those figures are based on the studies that this recommendation is based on. The aim of this type of exercise is for people with minimal impairments and to prevent deconditioning. In terms of working on your walking quality, there is strong recommendation to do this in a one-on-one therapy setting and to improve your spatial and temporal aspects of your gait. So therefore, what we're saying there is your accuracy, your step length, as well as your speed, your rhythm. So basically your coordination of your walking. The studies that this recommendation was based on used a variety of different interventions. One was a home exercise program that included a lot of good balance exercise, as well as a walking program. One was a dance-based video game. There's inpatient multidisciplinary rehabilitation and outpatient therapy. Balance training has a weak recommendation, and that's just based on the current studies that exist. And not to say that we shouldn't do that and we shouldn't do more research in this area. I'm definitely a firm believer that we should be doing balance training. And the interventions that this recommendation is based on include balance exercise, so static, staying still and reaching forward, for example. Dynamic, which is moving your base of support, shifting your feet around, working on your combining visual aspects of eyes closed, standing type things, and soft surfaces. Functional retraining, which means doing your everyday activities as a balance task, so walking, standing up, transfers, that kind of thing. Video game, dancing, as we mentioned before, and multidisciplinary rehabilitation. The dosage numbers there are quite varied, and that's again is based on the variety that's out there in the study. So it says the studies have done anywhere between 3 weeks to 9 months, and 1 to 5 days a week. So that further refinement is probably needed in this area. So on to what we did at St. Joseph's Hospital. So some of you may or may not know, but St. Joseph's Hospital takes in inpatient rehabilitation for people with Huntington's across New South Wales. And what we did is those that were admitted were enrolled into the study for our HD4s. What we did when people entered the study, we looked at their UHDRS scores, which is similar to the Parkinson's score. So in this case, it's the United Huntington's rating scale. So that some of you be probably very familiar with having undergone the test, where we're testing your finger tap speed, tongue protrusion, that type of stuff, walking, retropulsion, where they pull you backwards, that one. The Mocha and Stroop, which are two different thinking tests. The IPAC, which measures your physical activity, and the EQ5D, which measures your difficulty performing daily tasks. We also performed measures on functional outcomes, so the timed up and go, how far you could walk in 6 minutes, balance test with your Berg and Tonetti, and a FIM score, which is a functional independence measure, which measures all aspects of your ability to care for yourself. Toileting, showering, dressing, communication, mobility, all those things. So it's an all-encompassing functional score. We also try to collect falls history. So for those that we knew were coming into St. Joseph's, we attempted to give a diary to have a prospective falls data 3 months prior to admission. If we didn't have that, then we were relying on retrospective recall with care verification where we could. Unfortunately, though, that comes with a bit of bias in that. We also looked at people's walking on a Xeno walkway, which is an electronic mat, which would measure very fine detail your walking speed, your stride length, your step width, that kind of stuff we've mentioned before. We also did that with a dual task component as well, which was counting backwards. Now, what we did, so it is multidisciplinary inpatient rehabilitation. So we had physio, OT, social work, dietitian, medical and nursing care. Average length of stay was 13 days, and the typical dosage of exercise you would get from the physio side of things was about 45 minutes, twice a day on the weekdays. And the exercises that we provided was gait retraining, dynamic balance training, cognitive and upper limb dual task with functional tasks, mostly walking, and a lot of strength and aerobic training as well. So just as a broad level, that's what we did. It's up to the clinician, obviously, to shape the intervention to what they think that the client's needs are. So what we found for some of the baseline characteristics, if we divide our cohort into fallers and non-fallers, in this case, we're defining fallers as anyone with 1 or more fall. So we found there was 37 fallers versus 24 non-fallers. And if we split on this definition, we find that the fallers tend to be a bit older. So 57 versus 49 years old. Females are more represented in the faller group. In the non-faller group, it's the reverse. It's about 70% are male. As a whole cohort, though, it is a 50-50 split of gender. With fallers tended to have a higher score, so a worse score on the UHDRS, lower levels of self-reported quality of life and lower levels of activity and lower scores on cognitive testing on the Stroop word. And these are actually quite similar results to what we found on a larger study we're doing at the moment with our HD Enroll project, where we're looking at a lot of differences between fallers and non-fallers. So a fair few similarities there, and that's with thousands of subjects, whereas this one is only a very small number. In terms of the functional outcomes, so what actually happened, the changes that occurred to people that underwent this multidisciplinary rehabilitation, we found that there was a lot of positive changes. So we can see that the distance walked in 6 minutes improved by 21 meters, timed up and go scores reduced, Berg balance scores improved, and Tonetti scores improved, as well as the FIM score. In terms of statistical significance, for those that are interested, they're all statistically significant, except for the timed up and go score change. Now, if we split those outcomes between non-fallers and fallers, what we can see here, we can see some baseline differences between the two groups. You can see there's a fair bit of difference between the 6-minute walk test performance, whereas non-fallers are walking over 100 meters more at baseline. Timed up and go scores are a lot faster, Berg balance scores and Tonetti scores, so better balance to begin with, and higher scores on the functional independence measure. In terms of the change as well, in terms of improvement, both groups demonstrated improvement. And you can see that the change numbers here of how much improvement occurred by. And you can see that also in the fallers group, we did also have improvement. And you can see that where the asterisks are is the figures with statistical significant change. So the other interesting thing to note is with the fallers, the timed up and go and the Tinetti score was consistent with previous research about the risk of falling. So you can see the timed up and go score is 15.9 seconds, where the cutoff previously mentioned was 14 seconds, and the Tinetti score was 21 and under, and fallers were scoring on average 19.1. Berg balance is just on the threshold of 40, with a score of 41.1. I think one of the key messages here is that if you're a non-faller, you should still be doing a lot of exercise because there is still a lot of benefit to be had. And if you're a faller, you can still benefit as well. And it's important to consider the importance of exercise across all stages of Huntington's. One of the other interesting things I wanted to show with the faller group tend to have a bit of a bigger improvement in their balance scores with Berg balance and Tinetti, and they were also statistically significant change. And so that's a good sign that, you know, if balance is one of your contributing factors to falling, we still can make positive change in this area. If we move on to the walking scores with the walk mat that we used, we can see that as an overall group that we see positive change in walking speed and in your stride length, the stride time, your stride width, and your double support time. So the double support time, just remembering, is the time that you spend in 2 feet on the ground. In terms of statistical significance, cadence and stride width weren't statistically significant changes there, but overall change is positive. Now, I just wanted to talk quickly about the differences, the effects that dual task walking that we found on the people that had gone through the study. So we found that with our cognitive dual task with walking, the velocity, your walking speed goes down, your rate of stepping reduces, your stride length reduces, your time to take a step also gets slower, and your stride width, you take a wider step as well, and your double support time increases, which is a sign that you're becoming more unsteady. And just to show what actually happened with any changes in the dual task outcomes. So fairly modest change overall, but I think the one thing that sort of stands out for me is that stride length improved by 7.4 centimeters under the dual task condition, and that was statistically significant. And that's a bit bigger than just your general single task gait, where the stride length improvement was only 3.9 centimeters. So it's interesting that with inpatient rehabilitation, you can still improve your gait under dual task conditions, which is important to know. And in terms of comparing the differences in falls, the 3 months prior to admission and the 3 months after admission, we found that the overall proportion of fallers and non-fallers didn't change too much. Though mean fall, the average number of falls did reduce after inpatient rehabilitation. But there is a wide range of numbers here. You can see the maximum falls here is 120 falls. So that obviously inflates that average number. So a lot more work to do to look at these numbers, but I thought it'd be interesting for people to see what the results we've had so far. But we should also probably say that we shouldn't take all the numbers as complete truth. There are some limitations with the study we should mention. But before I mention that one, I think one of the key messages with the HD4 study is that we were able to demonstrate positive impact on functional and gait outcomes and falls risk factors. Fallers and non-fallers alike both benefit from inpatient rehabilitation, but we still need to do some more work on the analysis, probably comparing different stages of Huntington's with their outcomes, fallers versus non-fallers at the 12-month time span, and we should probably looking at recurrent fallers versus single fallers as previous studies. A few things to mention about this study. It's a observational study, so there's no randomization. It was designed to fit into routine clinical practice. No control group and no blinded assessors. So we need to take these numbers knowing this. Also, that the intervention is a multidisciplinary approach. It's difficult to pinpoint a specific therapy as the key factor here. And that the FORS data, there were some difficulties collecting quality data. Though I must say that the prospective data we collected with weekly phone calls to participants so that so we could reduce the recall error there. In terms of future direction, so I think where we need to move towards is understanding how much better we can be with our intervention, how much we can be a lot more specific in terms of dosages, in terms of modality, in terms of frequency and setting, but that takes larger randomized controlled trials. I think the other thing that's important is that we need to identify those at risk of falling better. We're doing some work there at the moment with some predictive modeling, the HD Enroll database. And so I think that's also good to know that if you're going to be at risk of falling so that we can intervene a bit earlier. The other thing to consider, obviously now in our COVID world, to consider the correct model of care and the correct setting that suits different preferences. Obviously, people from a rural setting, especially New South Wales, there's vast distances to cover to attend appointments, and access can be quite a tricky thing. Now that telehealth is here, we need to look at that and suitability of telehealth for our HD clients, and to also think about who should be going through community home-based therapy compared with outpatient and inpatient rehabilitation, which is a lot more resource intensive. So there's a lot more to figure out. But overall, I think hopefully what this talk has helped is just increase the client, carer, and family empowerment about the importance of exercise for people with Huntington's, the importance of falls prevention, to work on gait, to work on aerobic capacity, strength, to work on balance. And it's an important part of quality care for people with Huntington's. Great. Thanks for listening, everybody. Just stop the share.
And thank you very much, Kenny. I was listening so intently and taking so many notes. That was really excellent.